Hi, I'm Pedro Barata. I'm a GU medical oncologist at the University Hospital Seidman Cancer Center in Cleveland, Ohio. We know that angiogenesis is a very, very important molecular pathway in renal cell carcinoma. And we know that from not only preclinical, but also clinical studies. Actually, kidney cancer is considered a highly vascular tumor type. What that means is there's an expression of these angiogenic factors, such as vascular endothelial growth factors, known as VEGF. And that allows the tumor to actually form new blood vessels, thus growing and expanding. So actually that became a tool because we're offering a new opportunity of treating these patients by inhibiting this angiogenic phenomenon and this angiogenic pathway to treat kidney cancer. Inhibition of VEGF is a well-established treatment approach. It is well-established not just in the front line, but also in the refractory setting. And the reason why we know that is actually patients who progress on prior VEGF inhibition continue to benefit from subsequent therapies blocking this molecular pathway. So the inhibition of VEGF is actually the backbone of RCC therapy. And I think one of the take-home message is that actually the sustained VEGF blockade remains a critical therapeutic strategy throughout the RCC disease course. VEGF inhibition emerged in a very, very important treatment strategy in advanced renal cell carcinoma. We do that by blocking the VEGF family, including VEGF-A, B, C, E, and we have different ways of doing that. One way is using the small molecules called tyrosine kinase inhibitors, and by doing that, we're able to actually stop the tumor growth and proliferation by stopping the proliferation of blood vessels. FOTIVDA has unique properties as a VEGF TKI. I'm thinking the high potency and selectivity towards VEGF, as well as the long half-life. It makes it different from other angiogenic therapies available. Keep in mind that renal cell carcinoma is a vascular tumor disease. So our goal is to find a treatment that, on one end, specifically blocks that pathway, and on the other hand, is able to avoid or minimize unwanted off-target effects. We have a number of angiogenic therapies out there that we can use for patients with advanced renal cell carcinoma. One of them is FOTIVDA. And FOTIVDA, is highly selective VEGF antiangiogenic drug. In my opinion, is a very important aspect of this specific agent, and I do think it's a very valid option for patients who were previously treated with 2 systemic therapies, as has been shown in a phase 3 trial. Clinical guidelines like the NCCN Guidelines are really important for the care teams who are managing patients with advanced renal cell carcinoma. For instance, when we have a patient in front of us who has failed 2 systemic therapies for advanced RCC, actually having an easy access tool like these NCCN guidelines to refer to is really, really helpful. So I think it's really important to have therapies such as FOTIVDA being supported by level 1 evidence in those cases, because it makes the physicians' lives much easier about what's the right treatment to think about for a particular patient. TIVO3 is a prospective phase 3 study that included 350 patients with refractory clear cell renal cell carcinoma who had 2 or more prior systemic therapies. Patients in this trial were stratified by IMDC risk category and prior therapies. Actually, TIVO3 was one of the first phase 3 trials to include patients who were previously treated with a number of therapies, including checkpoint inhibition and a prior TKI, 2 prior VEGF TKIs, and a prior VEGF TKI in other systemic agent. The primary endpoint of this study was progression-free survival, assessed by a blinded independent review committee. And secondary endpoints of interest were overall response rate, duration of response, overall survival, tolerability, and safety. FOTIVDA is actually the first and only treatment with phase 3 data to support it for adult patients with refractory advanced RCC following 2 or more prior systemic therapies. In the pivotal study, TIVO3, it does provide the largest amount of prospective data generated to date, in a positive trial regarding the use of a VEGF TKI in a population that received 2 or more prior therapies, including immune checkpoint inhibitors. The data that comes out of TIVO3 has, in my opinion, clinical value. It's the first and only phase 3 prospective data post-second line, and it can actually help driving treatment decisions for this patient population. The data that we collected, was presented from the patients that were enrolled in TIVO3 really reflects how we manage RCC these days. And this is because, patients who were randomized to tivozanib or sorafenib were previously exposed to many different therapies. That includes immune checkpoint inhibitors, different TKIs, as well as other therapies such as interferon or IL-2. So it does reflect the way we are managing in the real world patients with refractory renal cell carcinoma. So to me, it's really important to support our treatment decisions in clinical practice. The primary endpoint of TIVO3 was progression-free survival. In the graph, we can see the progression-free survival landmark analysis, in my opinion, very, very important because it shows us what happens over time. And one of the things we see automatically is actually the early separation of the curves, favoring the FOTIVDA treated patients compared with sorafenib. At 1 year, we had 28% of FOTIVDA patients being progression-free compared to 11% in the sorafenib arm. And at 2 years, we had 18% of FOTIVDA compared to 5% with sorafenib as far as progression-free. So in other words, patients treated with tivozanib had a median PFS of 5.6 months compared with 3.9 months for the sorafenib arm. That's a risk reduction of about 27% or an hazard ratio of 0.73, which is clearly demonstrated in this graph, and it kind of favors the long-term activity of tivozanib here compared with sorafenib. The exploratory analysis of the progression-free survival data, which is the primary endpoint, by prior therapies, it's very relevant, in my opinion. We basically broke down the enrolled patients in 3 groups depending on the prior therapies patients were exposed to prior to getting on study. The first group, including 91 patients previously treated with a VEGF TKI and checkpoint inhibition. The hazard ratio was 0.55, favoring the group of patients treated with FOTIVDA compared with sorafenib. The second group included 159 patients treated previously with 2 VEGF TKIs. And here the hazard ratio was 0.57, again favoring the group of patients treated with FOTIVDA compared with sorafenib. And finally, we had the group of patients, about 100, treated with prior VEGF TKI and other systemic agents. And we've seen an hazard ratio of 0.98 for FOTIVDA and sorafenib, respectively. It's really relevant to have a good representation of all the available systemic therapies out there before enrolling this study, because that gives us more confidence of the way we are managing patients with advanced RCC upon progression. Receiving tivozanib seems to be an effective compound. Overall response rate, duration of response, and overall survival were important secondary efficacy endpoints of TIVO3. Keep in mind that TIVO3 patient population was post 2 or more prior therapies. And here with FOTIVDA, the overall response rate was 18% compared with 8% with sorafenib. And the disease control rate was 73% of patients who were treated with FOTIVDA compared with 65% of patients treated with sorafenib. Duration of response showed that 71% of the patients who had achieved a response with FOTIVDA were still responding at 12 months. Some of the efficacy results out of TIVO3 are really relevant in clinical practice. For instance, when we think of how long patients are actually staying on therapy without progression, it's really meaningful, and we can get that by looking at the long tail of the Kaplan-Meier curve that we see on TIVO3 favoring patients treated with tivozanib. Of course, we're looking for longer time. On the other hand, we have duration of response. That's truly important. When we see a patient responding to therapy, the next question is, for how long do we think the patient is going to keep that response going? So it's really important data to see and to have available. And if we go beyond response rate, if we're thinking about stable disease, so patients that have, tumor shrinkage that's not 30%, might be 5%, 10%, 50%, We also care about that, right? Because it's not just about, the deep responses that you're getting, but it's really about patients who are able to remain on therapy without having progressive disease. FOTIVDA has the first and only phase 3 data in the third line with 3 or 4 year landmark progression-free survival that basically evaluates the long-term disease control. The 1-year PFS rate with FOTIVDA was 28% versus 11% with sorafenib. The 2-year progression-free survival rates were 18% and 5% respectively. Upon 5-year follow-up, the landmark data show that PFS rates are consistently higher with FOTIVDA versus sorafenib, with 12% versus 2%, and then 8% versus 0% at 3 or 4 years respectively. So clinically, this is actually meaningful because we can look at the data, initially the initial readout of TIVO3, as well as the 5-year follow-up data to actually help answering what we can do in clinical practice for patients to get to this setting with the refractory RCC. For the FOTIVDA treated patients in this pivotal study, TIVO3, the most common adverse reactions were fatigue, ischemia, hypertension, diarrhea, decreased appetite, and nausea. When we look specifically at grade 3 or 4 adverse reactions that occurred with greater than 5% difference between the two arms, FOTIVDA had a higher rate of hypertension, but a lower rate of diarrhea, rash, hand-foot syndrome in comparison to sorafenib. The most common grade 3 and 4 lab abnormalities, of 5 or more percent, were sodium decreased, lipase increased, phosphate decreased, and lymphocytes decreased. When we look at the overall data, even though we had patients treated with FOTIVDA for a longer period of time than patients were treated with sorafenib, we still see lower rates of dose reductions, interruptions, and discontinuations for patients who were treated with FOTIVDA compared to those taking sorafenib. I think there's really important safety data that came out from TIVO3 that allows us to predict potential side effects and tolerability issues that can come up during treatment with these agents, right? Tivozanib and sorafenib. For example, although patients on the TIVO3 trial stayed on longer treatment with FOTIVDA, the number of dose interruptions, reductions, discontinuations were actually lower for that group of patients. And we're always, concerned with the potential benefit of a therapy compared to the potential risk. We don't want to harm patients, right? And the goal of the game in the refractory setting is really allow tumor control while they are able to tolerate medication and they continue living their lives. That's the goal that we have for this patient population. But it's also important, I think, that our experience in managing those side effects plays an important role. So for instance, I find it easier to manage hypertension than it is for me to manage diarrhea. And I would argue a lot of times hypertension tends to be more asymptomatic, if you will, compared to certain degrees of diarrhea. So that differences as far as adverse events is really important because it does make a difference between FOTIVDA and sorafenib, and it helps to make a decision about what treatment to give to patients in the refractory RCC setting based on the data from TIVO3.
Indications and important safety information. FOTIVDA is indicated for the treatment of adult patients with relapsed or refractory advanced renal cell carcinoma, RCC, following 2 or more prior systemic therapies. Warnings and precautions. Hypertension was reported in 45% of FOTIVDA-treated patients, with 22% of the events greater than or equal to grade 3. Hypertensive crises were reported in 0.8% of patients. Cardiac failures were reported in 1.6% of FOTIVDA-treated patients, with 1% of events reported as greater than or equal to grade 3. 0.6% of events were fatal. Monitor for signs or symptoms of cardiac failure throughout treatment with FOTIVDA. Cardiac ischemia in FOTIVDA-treated patients were reported in 3.2%. 0.4% of events were fatal. Arterial thromboembolic events were reported in 2.0% of FOTIVDA-treated patients, including death due to ischemic stroke, 0.1%. Venous thromboembolic events were reported in 2.4% of FOTIVDA-treated patients, including 0.3% fatal events. Hemorrhagic events were reported in 11% of FOTIVDA-treated patients. 0.2% of events were fatal. Proteinuria was reported in 8% of FOTIVDA-treated patients, with 2% grade 3. Thyroid dysfunction events were reported in 11% of FOTIVDA-treated patients, with 0.3% of events reported as greater than or equal to grade 3. Withhold FOTIVDA for at least 24 days prior to elective surgery. Do not administer FOTIVDA for at least 2 weeks after major surgery and until adequate wound healing is observed. RPLS, a syndrome of subcortical vasogenic edema diagnosed by MRI, can occur with FOTIVDA. FOTIVDA can cause fetal harm. Advise patients of the potential risk to a fetus to avoid becoming pregnant and to use contraception during treatment and for 1 month after the last dose of FOTIVDA. FOTIVDA 0.89 mg capsule contains tartrazine as an imprint ink, which may cause allergic-type reactions, including bronchial asthma, in certain susceptible patients. The most commonly reported adverse reactions were fatigue, asthenia, hypertension, diarrhea, decreased appetite, nausea, dysphonia, hypothyroidism, cough, and stomatitis. Serious adverse reactions included bleeding, venous thromboembolism, arterial thromboembolism, acute kidney injury, and hepatobiliary disorders. Avoid co-administration of FOTIVDA with strong CYP3A4 inducers. Advise women not to breastfeed during FOTIVDA treatment and for at least 1 month after the last dose. The recommended dosage for patients with end-stage renal disease has not been established. Reduce the FOTIVDA dose for patients with moderate hepatic impairment. The recommended dosage in patients with severe hepatic impairment has not been established.